Thank you, Chairman. It's a great honor for me to have a chance to speak at the heart of Japan, and I truly appreciate the opportunity. My talk today will be about the role of 24-hour monitoring of blood pressure and ocular perfusion pressure in normal tension glaucoma. Most of us are born with a normal optic disc, but some people develop glaucoma. Especially in Korea and Japan, the prevalence of NTG is very high, consisting of more than 70% of all open-angle glaucoma. Let's briefly think about blood vessels around the eyeball. An ophthalmic artery divides into two branches. One is the central retinal artery for the retinal circulation, and the other is the posterior ciliary artery for the choroidal circulation. Optic nerve head circulation is a little bit complex. The superficial RNFL is supplied by the retinal arterioles and the lamina cribrosa by the branches of short posterior ciliary arteries. There are two major risk factors for glaucoma. One is IOP-related mechanical stress, and the other is vascular factor. The result is a glaucomatous optic neuropathy. In glaucoma, we need to pay attention to what lies beyond phenomena. Sometimes systemic and local hemodynamic components may play some role in pathogenesis. All risk factors such as intraocular pressure, blood pressure, or autonomic dysregulation are so complexly linked to each other. It's not an easy job to take everything into account and investigate every cause and effect relationship. Blood pressure has a rhythm. Normal healthy people have physiological nocturnal blood pressure reduction of about 5 to 10% when compared to that of daytime. The circadian rhythm of hemodynamic parameters such as heart rate or BP is associated with circadian fluctuation of plasma catecholamine level in our blood. For the last several years, Dr. Cook and I have done some studies together to reveal the role of blood pressure and ocular perfusion pressure in antigen pathogenesis. All individuals have different pattern of circadian BP variation. In some patients, there is a relatively prominent BP reduction during the nighttime. We call them overdeepers. This slide from one of the landmark studies in normal tension glaucoma by Dr. Jones from Canada. It's also well known that patients with progressive glaucoma tends to have lower blood pressure at nighttime than stable patients. As like circadian BP fluctuation, each individual has their own pattern of circadian BP fluctuation. Research in IOVS revealed that about half of the NTG patients showed that their peak IOP during daytime, whereas others showed their peak IOP during nighttime or no specific pattern. Let's get back to the complex diagram again. From the diverse risk factor, like Father, Son, and Spirit, and the theory of Trinity in Catholic Church, we can extract Trinity components of normal tension glaucoma: IOP, BP, and its disturbed autoregulation. I believe that ocular blood flow stands in the center of this Trinity angle in antigen pathogenesis. We can calculate ocular perfusion pressure and take it as a surrogate parameter for ocular blood flow. Ocular perfusion pressure is derived from the difference between mean arterial pressure and intraocular pressure. Ocular perfusion pressure depends on the postural change, sitting or supine, as hydrostatic pressure changes. Several years ago, we thought that we need a new parameter which can reflect unstable ocular blood flow and design a concept of 24-hour MOPP fluctuation. This parameter was defined as the difference of peak and trough MOPP measured during 24-hour hospitalization. In sleeping laboratory, we separately measure BP by ambulatory BP monitoring device and IOP every 2 hours by a resident doctor. Then we synthesize BP and OPP into one parameter called MOPP. What happens if the patient has unstable ocular blood flow? Here we have a very excellent slide by Dr. Joseph Flammer. Unstable ocular blood flow can induce ischemia or reperfusion damage in the mitochondria of cells in glaucoma patients. I'll briefly summarize our study findings. First, nocturnal BP over-DPing affects 24-hour MOPP fluctuation in NTG patients. You can see increased 24-hour MOPP fluctuation in nocturnal BP over-DPers. Second, increased 24-hour MOPP fluctuation is proportional to advanced structural and functional damage in NTG patients. We measured the structural parameter by OCT and functional parameter by Humphrey visual field indices and found out that significant correlation is present between 24-hour MOPP fluctuation and these parameters. Third, increased 24-hour MOPP fluctuation is the most consistent risk factor for NTG development. Using multivariate regression analysis, 24-hour MOPP fluctuation was the most frequently associated risk factor with functional and structural glaucomatous damage. Fourth, increased 24-hour MOPP fluctuation is also associated with NTG progression. Kaplan-Meier survival analysis revealed that high cumulative probabilities for progression in groups with high 24-hour MOPP fluctuation. Fifth, increased 24-hour MOPP fluctuation is associated with central visual field progression. Using multivariate Cox proportional hedges model, 24-hour MOPP fluctuation remained as the only significant predictor for central visual field progression. Why is central visual field loss important in glaucoma? Because central visual field loss can worsen the quality of life much more than peripheral visual field loss does. Our daily activities such as reading and object identification depend much more on the function of fovea and central macular region. Very recently, Dr. Rich's group showed that specific macular region covered by inferotemporal RNFL bundle is more vulnerable to glaucomatous damage in the central 10 degrees of the visual field. We recently added a new idea that in patients with high 24-hour MOPP fluctuation, visual field defect within central 10 degree progresses faster than in other groups. There is no difference in the rate of peripheral visual field progression among groups. Additionally, we found out that high 24-hour MOPP fluctuation and worse baseline MD value at initial visual field test are the significant risk factors for predicting central visual field progression in NTG patients. Why does central macular area seem so vulnerable to 24-hour MOPP fluctuation? Anatomical explanation will be that there are different vascular support systems between the peripapillary area and the central macular area. In the peripapillary area, there is multi-layered capillary supporting system. Radial peripapillary capillaries supply the retinal nerve fiber layer around the optic disc and are connected with capillaries in the ganglion cell level, so they have dual supply. This makes dual blood supply possible in the peripapillary area. In contrast, there is no LPC in macula, and central macular area is bordered by the single-layered perifoveal capillary arcade. Microvascular dysfunction in NTG may be an answer to this question. Untreated NTG patients showed a steeper retinal artery dilation and constriction response associated with flicker response, whereas normal healthy people showed double hump response, double hump and slow response. In heart and brain, microvascular angina where microvascular brain infarct can occur. In these conditions, tissue damage happens in watershed zone or at the most distal area between arterial territories. I think central visual field progression in the group of high 24-hour MOPP fluctuation has a lot of things similar to these disease categories. The summary of our hypothesis. First, high 24-hour MOPP fluctuation may induce daily repetitive ischemia reperfusion insult. Second, macula is weak capillary supported area. Third, ganglion cells in macular area are more vulnerable to the unstable IVF. In conclusion, central visual field defect may progress faster in the group with high 24-hour MOPP fluctuation. Lastly, let me show a brief sample case. This patient has undergone meaningful central visual field progression over the last few years. The ganglion cell analysis by CIRCADIAN also showed the structural progression. We performed 24-hour BP and OPP measurement, and the profile summary revealed that this patient has very wide range of systolic, diastolic, and mean arterial pressure. Peak MOPP was measured at 6 a.m. and trough MOPP was measured at 4 a.m. You can see nocturnal BP reduction is very prominent around 4 a.m. We also took fluorescent angiography for this patient and noticed an interesting thing. The border of relatively hyperperfused area in only face of FAG nearly coincides with the area of thinned ganglion cell layer detected in the macular cube scan by CIRCADIAN. What comes in my mind is that FAG, especially in early phase, may give some clue for the future ocular blood flow studies. Take-home messages. Reduction of blood pressure during the night time has an influence on ocular blood pressure, ocular perfusion pressure. Increased 24-hour MOPP fluctuation is the most consistent risk factor for antigen development and pathogenesis. Central visual field may be affected more severely than peripheral visual field and antigen patient with high 24-hour fluctuation of MOPP. Thank you for your attention.